Welcome everyone to the Department of Medicine Research Grand Rounds. I'm Dr. Jennifer Cook, one of Dr. Williams' vice chairs, and so he's in France right now, joining us virtually, but I'll go ahead and do the introductions of our speakers today. So we have two speakers today. First, Dr. Craig McClain, who's a professor of medicine in our Division of Gastroenterology, Hepatology, and Nutrition, and Director of Gastroenterology at the Louisville VA Medical Center. He serves in multiple leadership roles related to research. These include Chief of Research Affairs for his division, Director of the Liver Research Program, Distinguished University Scholar, Associate Vice President of Translational Research, Director of the Clinical Trials Unit, Associate Vice President of Health Affairs Research, Deputy Director of the Clinical and Translational Sciences Institute, and Co-Director of the Institute for Nutritional and Metabolic Therapeutics. His CV lists over 550 peer-reviewed publications, and in 2024, he was named among the top 2% most cited authors in the world, according to a list compiled by Stanford University and Elsevier. And I had merely scratched the surface of summarizing his CV, but we'll leave it at that for now. And our second presenter is Dr. Irina Kirpich, who is an associate professor in the Department of Microbiology and Immunology. She's been on staff and faculty at UofL since 2006. She's dually appointed in the Department of Pharmacology and Toxicology, reflecting her varied research pursuits across 18 years of investigation. She currently holds several grants, including an R01. She provides leadership at the national level through committee appointments for the American Association of Clinical Chemistry and the American Association for the Study of Liver Disease, as well as having served on NIH study sections. What's perhaps most impressive about Dr. Kirpich's accomplishments is the extensive mentorship she has provided to trainees from all levels, from high school students to K Award mentoring and every level between. So welcome to you both. And today we'll be hearing about managing alcohol-associated liver disease, the role of nutritional therapy. Please help me welcome our speakers.
Thanks, Jen. And I want to thank Dr. Williams for inviting us here today to give research grand rounds on a topic that's an area I've worked in for over 40 years. And Jen mentioned mentoring, that's probably one of the things that I enjoy doing most. And Irina was actually one of my postdocs several years ago. And now she's not only nationally recognized for her research, but also her mentoring. So we're doing a tag team today. Part of that is because what Jen didn't mention, I also see a truckload of patients, and I have a grossly overbooked clinic this afternoon with a whole lot of patients. And I want to thank the residents that go to my clinic. Some of you are here today. I couldn't do that without you. So I'm going to talk a little bit more about the clinical aspects of things. And then Irina is going to talk some about our basic research that we do. So our objectives are to be able to describe the prevalence and implications of malnutrition, assess malnutrition, identify causes, provide appropriate therapy, and then Irina is going to go over some novel therapies. So the real focus today is our treatment with a focus on nutrition. And so this is the spectrum of alcohol-associated liver disease. So over here is fatty liver, which I know I've had at one time, and probably some of you had too. We'll talk about that a little bit. It can go on to steatohepatitis. What we don't want is cirrhosis, and what we really don't want is liver cancer. We define alcohol-associated hepatitis by clinical and biochemical parameters. So severe AH is a MELD equal to or greater than 21, moderate any under 21. Early ALD is having elevated liver enzymes, but not bilirubin. And then we have compensated and decompensated cirrhosis. So our terminology has changed. So we try and do away with pejorative terminology. So we don't say alcoholic, we say someone who misuses alcohol. And we try to do that to get more people into treatment. We don't want them to feel like they're being discriminated against. And we'll talk about how important treatment is. The liver community in general has renamed all of their steatotic liver diseases. So we used to say NASH over here, now it's MASH. So metabolic dysfunction associated liver disease. We even made up a whole new category called MET-ALD. So that's metabolic dysfunction and ALD put together. And this really bloomed during COVID. So what were people doing during COVID? They were sitting home eating and drinking. So the two together causes me to see twice as many people in clinic. And then we have alcohol-associated liver disease. So there's a great NIAAA sponsored website, Rethinking Drinking, that you can look at to get all the information that you need to know about drinking. But this is what a standard drink is. So it's 14 grams of alcohol. This is what I have every night, a little bourbon. Matt Cave in our group probably drinks beer. You can take your choice. But what I want you to focus on is over here, what people drink. So the current guidelines say that for a woman, and this is very discriminatory. So for a woman, you can have 1 drink a day or less, for men 2 a day or less, and that's moderate drinking that probably is not supposed to harm you. This is what our patients at Jewish have with liver disease. They're drinking about 15 drinks a day. But interestingly, if you go over to JDAC right across the street and see if you have a patient in a treatment program there, and they don't have any liver disease, they're drinking about 15 drinks a day. So our patients with alcohol misuse don't just kind of go up from 2 drinks to 3 or 4. They're drinking a lot of alcohol. This is industrial drinking. So who gets ALD? Well, back in the old days, a friend of mine, Charlie Lieber, did this study at a VA hospital where he took people that wanted to be GI fellows and said, hey, you know, get into the fellowship and do a little research here. So we can't do that anymore. So what he did is he took a bunch of people and he did a baseline liver biopsy, then brought them into their clinical research program, fed them alcohol for 2 weeks. They loved that, and kept their blood alcohol level close to the legally intoxicated limit, then did another liver biopsy on them. And so that's shown here. So the baseline, no fat, here a lot of fat, the open circles are the fat, and the liver enzymes also went up. And for some of the really lucky ones, they went off alcohol for a couple more weeks, did another liver biopsy, and everything came back to normal. So if you drink heavy for a couple of weeks, why you can get fatty liver, but it reverses. Our diagnosis again is by chemical and clinical criteria. And so you're drinking a lot of alcohol, your bilirubin has to be elevated. And then again, severe is a MELD equal to or 21, moderate is under 21. Now, our diagnostic dilemma was here. So our person with alcohol steatotic hepatitis used to look like this. This is one of my people from a VA cooperative study several years ago. So a lot of sarcopenia. Here's our classic patient with MASH. And here we used to call this BASH, both. Now we call it MET-ALD. And again, we see a lot of that. So we now have a new terminology there. So what about therapy? Well, it's kind of like an inverted pyramid. And so everybody should get lifestyle modification. And what we're going to focus on today is almost everybody. In fact, I think everybody should get nutritional therapy. Some people will get drug therapy and a few transplantation. So for alcohol use disorder, the important concept is we need to be treating everybody, and optimally everybody would get both psychosocial intervention and pharmacologic intervention. So here's a study that we did recently with the Medicaid database in Kentucky. So under 10% of people will get any type of drug therapy. So if Dr. Williams is on here, I think he'd be really annoyed if only 10% of his people with hyperlipidemia were on a statin. And under 25% get any type of therapy. So we do a lousy job of this. And hepatologists especially don't get people into AUD therapy. And so now in a new grant that we have, we're forming teams to work on group therapy. Almost everybody with severe AH has some degree of malnutrition. So the best test in this study was the creatinine to height index, where 100% is what you should be. And you can see even with mild disease, they were only at 3/4 of normal, and it got worse with more severe disease. The causes of malnutrition are multiple. And so our patients tend to have anorexia with altered taste and smell. Many of them have delayed gastric emptying. Something that I work on, cytokines cause inflammation and catabolism. Then if they have big leg ascites, they don't feel like eating. If they're encephalopathic, they don't eat. And there are also social, racial, and economic issues. The issue in assessing nutritional status is many of the tests that kind of you commonly think about to look at nutrition are also altered by liver disease. Triceps skin fold or visceral proteins. So these are proteins like albumin. Well, albumin's made in the liver, so it's going to go down just with liver disease. Things that I like are muscle strength and a thing called bioelectric impedance that they do at a lot of health clubs now. But the machines now are absolutely fantastic at looking at body composition. Here's a hand grip dynamometer that we use, costs $100, and it's great for following up people. And so their muscle strength changes very quickly with their nutritional status. So this was a study that we did at the VA here, the VA in Louisville, and also the VA in Lexington, where I was at the time, and looking at the impact of malnutrition on outcome. And basically, this is a protein calorie malnutrition scale that we made. So 100% again is good. And over here in the, I guess this magenta is bad. And you can see a stepwise increase in mortality with malnutrition. Individual nutrients play a role. So we think about people being protein calorie malnourished, but especially protein malnourished. And we know that in most of the studies that we've looked at, people were eating only about 55, 57 grams of protein a day. And you have to have at least 85 to be in positive nitrogen balance. If you're having a high fructose, high alcohol diet, bad combination. Irina is going to talk about N6 fats being bad and N3 fats being good. Recent studies have highlighted the importance of fiber. So fiber intake correlates with severity of liver disease and mortality. And fiber is needed for production of short chain fatty acids in the intestine. There is no fiber in beer. What about nutrition support? Well, this study was done back in the 1940s, a great study by Arthur Paytak that stimulated interest in nutrition. And he ran a clinical research center. And basically, he went out to kind of homeless shelters and said, you know, come on into our research center and you get free meals, 3 meals a day. And so he's trying to get 3,000 calories and 100 grams of protein in them. And he showed that the people that participated had a much better mortality than those that didn't participate over a 5-year period. So then back to VA cooperative studies that we did, we looked at the amount of calories consumed related to mortality. And again, a direct correlation. So if you had severe alcohol-associated hepatitis and your average bilirubin 17, and you were taking in less than 1,000 calories a day, you were almost sure to die. On the other hand, if you were taking in around 3,000 calories, why, you were almost surely going to live. A big multi-center study from Europe confirmed that. Low calorie, low protein intake, bad prognosis. So we need to encourage people to have adequate protein and calorie intake. Now, this was a reanalysis of studies done at the VA where they gave, looked at dietary intake, and in the diet, they gave a enteral supplement to try and increase calories and protein. And then some people also got oxandrolone, and so an anabolic steroid. So the people who had moderate protein calorie malnutrition, the best group was the anabolic steroid and the adequate diet. If you had severe, the adequate diet was important. If you had an inadequate diet, but tried to force protein synthesis with oxandrolone, those were the people that had the worst prognosis. So very interesting data. And so to do well, you need a baseline of adequate protein and calorie intake before you try anything else. Special considerations. Our nurses up at Jewish were harassing us about this the other day, about putting a feeding tube down somebody with varices. There's no evidence that that causes bleeding. Don't protein restrict if you worry about encephalopathy, that if you protein restrict somebody, they're just going to break down their own muscle mass. And then you also have to remember more is not always better. So one of the things that we see with individual nutrients is sometimes people give too much. And some of these, like vitamin A, can actually be toxic. So our recommendations when people come into the hospital, the first biggie is getting enough protein in. Now, a lot of the patients that we see are actually significantly overweight. So there we like to put them on a hypocaloric diet that's high in protein. And we stress nighttime snacks. And that includes when patients go home as an outpatient. When I go over to clinic, that's what I'm going to be telling every one of my cirrhotics. Remember your nighttime snack, 9 o'clock at night. So they did a great study in Europe where they basically gave cirrhotics a nutritional supplement at 3 o'clock in the afternoon or 9 o'clock at night. And only the one at 9 o'clock at night kept people in positive nitrogen balance and maintained muscle mass. And the reason is once you're cirrhotic, your liver doesn't store glycogen. So you go into a starvation mode every night. But if you have that 9 o'clock snack, you're in good shape. So if you have moderate AH, so that's a MELD of under 21. The main form of therapy there is treatment for the alcohol use disorder and nutritional management. Now, this is a study, and again, guys that have been in my clinic know Dr. McClain gives culturelle all the time. What the hell's going on? So we've studied this starting out in the laboratory. So it's a specific probiotic. It's Lactobacillus jejuni, and it can be any brand that has that specific probiotic, and culturelle just tends to be the common brand. And what we showed in a multi-center study was that the people who got the LGG therapy had a better drop in their MELD score, in their AST and ALT ratio, but moreover, they had a marked reduction in their drinking. And we now know that there's a gut-liver-brain axis, and neuroinflammation drives drinking. And so this is basically a twofer. You're fixing the liver and the drinking. For severe AH, it's glucocorticoid therapy, and steroids bind to the glucocorticoid receptor in the cell. It goes to the nucleus, activates anti-inflammatory genes. So the big news here is you have to apply the Lilly stopping rule at 4 or 7 days. So basically, this is looking to see, is your bilirubin dropping or not dropping? So this study called the STOPPA trial was the big definitive multi-center study from Europe. And it basically showed that pentoxifylline wasn't particularly effective, and all these drugs, prednisone, had a minimal beneficial effect at 28 days. But the big thing was that the 90-day mortality was about 30%. And so that had dropped from about 50% previously. So good medical therapy was improving outcome. Well, this is a study that some of you guys referred patients to that we just finished. It was the LCAP-NET study. So we were comparing prednisone versus a IL-1 inhibitor that's used in rheumatology, anakinra and zinc. And so we thought, based on some animal data and early human studies, that this would work great. Well, this is why you have to do human studies. Actually, the prednisone worked better. There's only a 10% mortality. But this was the first study where everybody applied the Lilly stopping rule. And so the important concept here is that steroids aren't working at 7 days. Continuing them for the next 21 days, you're just going to get the bad side effects and kill somebody. So you got to stop the steroids. And so we're getting ready to do another study comparing steroids with interleukin-22. And we'll have that at all of our hospitals here, hopefully in the next 3 or 4 months. But there've been a bunch of recent negative trials on things that all made sense in animals, didn't work in humans. Some older drugs that are kind of plus minus in efficacy. These are some of the ones that we think may be a benefit in the future. These last two here are used in obese patients for weight loss, but we know that these drugs also actually decrease alcohol misuse. And again, there's this big gut-liver axis. So one of the things that we look at is the role of dysbiosis and liver disease. And so shown in this heat map here are butyrate-producing bacteria. So if it's green, that's good. If it's not green or red, that means that they're not there. And basically, if you have alcohol-associated liver disease, you don't have any butyrate. So that's a short-chain fatty acid. Remember, that's produced by bacteria fermenting fiber. And so we're doing a bunch of novel therapies here, nutritional therapies. And one of them is giving a butyrate prodrug called tributrin. And we have exciting results there. We also are giving omega-3 fats and resolvins, and Dr. Kirpich is going to tell you about that. So my take-home points are our patients are frequently malnourished. Traditional nutritional support improves nutrition, may improve outcome. It attenuates many of the mechanisms of liver disease. It's frequently overlooked. And again, we've got a lot of therapies in the pipeline. And let me stop here real quickly and see if there's any questions and turn it over to Irina. Yeah.
Two questions. One, what are your thoughts about? I've seen that they use filgastrin, a Jewish a bit what's it called, stimulating factor over there. What are your thoughts on like doing that versus the penicillin? And then I guess based on your previous slide, it's like if you put them on penicillin and then you don't feed them, they're probably going to do worse than if you would just not touch them at all.
For the steroids, you mean?
Yeah.
Yeah. So yeah, if you apply that stopping rule at day 7, and in our study, once you stop the prednisone, a large number of the people that should have died actually lived. So you're getting bad effects of prednisone in people that aren't benefiting. So that's what we learned from that. And then your other question related.
I just was curious about your thoughts about using the GCSF.
GCSF or others, yeah. So so that's used to stimulate liver regeneration, which is a problem in these patients. And I'm not a fan of GCSF. Dr. Marsano likes to give it. The issue with GCSF, it also drives your white count up. Those neutrophils are sort of circulating around. I think there's potential to do some damage. And especially when COVID was on, we couldn't tell whether people were getting GCSF or they had COVID when their neutrophils were up. So I'm not a fan, but we do need something for liver regeneration. Okay, great. Irina? So Dr. Kirpich is going to tell us about the lipid research that she does in her group. And I'm going to run over and start seeing patients that I'm sure are waiting for me. So guys, thank you very much.
Thank you.
As Dr. McClain mentioned, I spent my 20+ year of my career working in the alcohol-associated liver disease and dietary fat. What is good, what is bad, what is neutral. And today I'm going to talk about N3 PFAS. I'm not going to show you N6 PFAS or polyunsaturated fatty acids. I'll just mention about it. So this is a spectrum of liver disease. Everybody in this room knows. I don't need to go again. But what I wanted to mention is that we are working with alcohol-associated liver disease animal models. We're trying to mimic this condition in our animal models and try to apply our dietary supplementation or animal models to see if we can attenuate this disease. You saw that already from Dr. McClain's slide that people are drinking a lot. Not 1 or 2 drinks per evening, but about 17 drinks per day. And this is coming to about 1,700 calories, which basically can cover all daily calories. And this is in combination with our Western diet, which is unbalanced for different types of nutrition. High fat, high carb, low fiber, and specifically what my group interested in this balanced omega-6, omega-3 fatty acids. And this is coming from the last century when we Western society significantly increased consumption of omega-6 fatty acids in the expenses of omega-3 fatty acids. In a hunter-gatherer society, ratio between this and 6 and 3 was about 1. And in modern world, in the US, it's around 15. In Europe, it's 10, 11. And some rural villages, I don't know why in India, for example, they have about 50. So we really do have this balanced nutrition. I would like to mention here that we have a lot of research in animal studies, in preclinical animal models related to the dietary fat and ALD. And everything started from the early 1980s when an epidemiological study have been shown that dietary intake of unsaturated fatty acids was associated with a higher mortality rate from alcoholic cirrhosis compared to a diet rich in saturated fatty acids. Then bunch of preclinical studies were performed, and it has been shown that dietary saturated fats, specifically medium chain triglyceride, which are enriched in coconut oil, they were protected against ALD, and the unsaturated fats, specifically enriched in linoleic acid, exacerbate experimental ALD. So in linoleic acid, if you think about your kitchen, your oils you are using to fry your chicken, it's about 50–60% of linoleic oil in soybean oil, in canola oil, in grape oil, whatever oil you think about. If you have, for example, chicken, Kentucky Fried Chicken, there are a lot of oxidized linoleic acid metabolites, which we are thinking in our previous study showed they are pro-inflammatory molecules. So today I'm going to show you research for omega-3 fatty acids, which we are thinking is beneficial in ALD. For our studies, we are using animal model, which we called FAT1 mice. This is a transgenic mice. They have a transgene, FAT1 gene, which encode N3-PUFA desaturase, which convert omega-6 to omega-3 fatty acids endogenously. So these mice, they endogenously have higher level of omega-3 fatty acids in all organs, brain, liver, muscles, everywhere. So we don't need to feed them any special diet, which kind of eliminates this confounding factor. Here I show you a wild type and FAT1 mice, and data, which I will show you later, will be this color, FAT1 red and wild type blue. As I mentioned already, FAT1 mice, they have elevated levels of omega-3 fatty acids, EPA and DHA we measure here in all organs, and a decreased ratio omega-6 and omega-3. So we are using this model in our studies. So to simulate, as I mentioned already, the severe alcohol-associated liver disease, alcohol-associated hepatitis, we feed animals for a long time, like about 6 weeks, alcohol diet, about 5% per volume by volume. And then at the last day, we hit with LPS and the toxin, because the patients with age, they often has associated inflammation. And then 24 hours after the LPS hit, we sacrifice animals. As I mentioned, this model mimics the advanced age in humans. As you can see and can appreciate here in red, the ALT levels are significantly low in FAT1 mice, males and females, comparing to wild type animals. And this is associated with decreased liver inflammation. Here I'm showing you TNF-alpha, interferon gamma, CXCL10, NOS2, and several other parameters which we measure were significantly attenuated in FAT1 mice. So what is the mechanisms? I know that you are clinicians and maybe you don't care what's going on, but still. I remember being a little kid and my mom gave me fish oil capsule and I hated it. So at that point, kind of we knew that fish oil is beneficial, omega-3 fatty acids is good for you, but I didn't think about that mechanism. Now I kind of know, okay, mom was right that she just insisted me to take that pills. So about 10 years plus, the concept of the beneficial or metabolites of omega-3 fatty acids came to the research field, and they called specialized pro-resolving lipid mediators or SPMs. This is the derived from EPA and DHA. EPA gives E-series resolvins, RVE1, E2, and DHA, D-series, RVD1, RVD5. This is a spectrum of these molecules, and protaxin and myrcins. When we looked in our animals, we saw that RVD1 was significantly higher in the livers of these mice. That's what kind of, we were thinking that maybe these molecules, which considered to be pro-resolving anti-inflammatory molecule, is the driver or mechanistic underlier of our phenotype, which we see in our mice. So what is the kind of SPM's concept? What's the effects? It has been shown in multiple studies in different organs. They showed anti-inflammatory effect. They reduce LPS-induced pro-inflammatory cytokines and pro-resolving effects, switching macrophages from pro-inflammatory to anti-inflammatory, increase enterocytosis, regulate apoptosis, and they are also antifibrotic. What very important is that SPMs, they do not suppress immunity. This is very important in our field because patients with ALD, they have already immunocompromised. So we don't want to further suppress immunity. And again, as I mentioned, SPMs have been demonstrated beneficial effects in multiple animal models. So we were thinking, let us try and treat our animals with resolving D1. So we had the same model, which I showed you before. We fed animals for 4 to 6 weeks of with ethanol-containing diet. At the last week, we treated these animals with resolving D1 IP, and heated LPS with LPS like in previous model. So what we saw was animals which received RVD1 treatment had significantly less liver injury based on ALT levels, as well as less inflammation. Here I'm showing TNF-alpha and IL-1 beta. Again, this data demonstrate that most likely the phenotype which we see in FAT1 mice with decreased liver injury might be through the RVD1 molecule. What is the mechanisms? There are definitely multiple mechanisms which could be involved in these protective effects. We performed RNA-seq, and we saw one of these sets, which we kind of draw our attention, was a set of proteins involved in the pyroptosis. Pyroptosis is the programmed cell death, and this type of cell death often seen in patients with ALD, specifically with PH. And the end point of this cell death is IL-1 beta and IL-18 release to pro-inflammatory cytokines. So when we looked at the caspase 11 and gasdermins, which are molecules involved in this pro-inflammatory pathway, we saw that mice treated with RVD1 had significantly decreased level, both caspase 11 cleaved and gasdermin cleaved, and their levels of IL-1 beta, as I have shown already, was significantly decreased. So we are thinking that omega-3 fatty acids are beneficial in ALD, in part via the RVD1 related suppression of pyroptosis. So this is animal studies that I showed you very short, and one of the multiple studies which we perform in our group. But what about human studies? Is any evidence from clinical studies that omega-3 fatty acids are beneficial? So we were lucky enough, and we collaborated with NIH clinical trial. They performed clinical trial when in early 2000s, when they admitted to the clinic heavy drinking individuals to detox program. These individuals were in the program for 21 days. And after the discharge, they were randomized to the active agent, which was omega-3 supplementation, 2 grams per day, DHA and EPA, or placebo. Patients were followed for 12 weeks, and after the 12-week study was considered completed. So the blood and CSF samples were collected at admission, at randomization, and at the study completion. So this study was not designed to look for the liver injury. They were looking for the aggressive behavior, but we were lucky enough to get all samples of blood and CSF to our lab. So here is the demographics for this study. It was 96 patients randomized, and about similar numbers in control and in TRIPUFA groups. Age was about 39, 40 years. So, and it was male and females in this study. So when we got CSF samples, first which we looked at was the levels of EPA and DHA. Here is a group of a TRIPUFA supplementation, and here is a placebo. As you can see, baseline first point, and the second point is in TRIPUFA after 12 weeks of supplementation. So you can appreciate that omega-3 fatty acids, EPA and DHA were increased in the treatment group or supplemented group, and that was not the case in placebo group. EPA even was significantly low, suggesting that the protocol worked, and suggesting the adhesion of these patients to the treatment protocol. So then we were looking at the markers of liver injury, ALT, AST, and GGT. And as you can see, again, on the left side is a TRIPUFA arm, and on the right side, a placebo arm. So as you can see, ALT levels were significantly decreased as the GGT. AST was not kind of significant, not reaching significance in patients with TRIPUFA supplementation, which was not a case in the placebo arm. So as Dr. McClain mentioned, that in detox programs, people are not coming because of the liver problem, because of the AUD. So our previous study and this study showed that about 60%, no, 37% patients had elevated liver enzymes, and 67% had normal ALT. Our previous study showed about 50% of AUD patients admitted to detox program had elevated ALTs. And as you can see here, those who had elevated liver enzymes after discharge, their liver enzymes were not normalized. So what we did next, we separated to the group where we had a group with elevated liver enzymes, with ALT more than 40. We removed or we did not take into consideration patients with less than 40 units per liter ALT levels, and look what how these parameters behave after the 12 weeks of supplementation. And as you can see, again, in a 3-PUFA arm, we see significant decrease, elevated enzymes, which was not the case in the placebo arm, suggesting that 3-PUFA supplementation really resulted in decreased ALT levels if these levels are increased before randomization. So we also saw that in placebo arm, it was a significant increase in the blood LPS level as a marker of the intestinal permeability, and patients with 3-PUFA supplementation, they did not have increase in ALD, suggesting that 3-PUFA is also beneficial to the gut as well as to the liver. So key takeaways from our preclinical and clinical studies is that we do really have evidence from experimental and clinical studies demonstrating beneficial effects of omega-3 fatty acids, endogenous enrichment or supplementation in alcohol-associated liver injury. And of course, future investigations are needed on mechanistic roles, and we want to know more about the resolvents, how they perform. And of course, we wanted to design the clinical study, which will look for the liver endpoints and intestinal endpoints as the primary endpoints. And thank you for your attention. And if you have any questions.
3 minutes for questions. Any questions from our audience?
So I would like to conclude that I'm surprised that nobody asked a question, but I did not show you data for N6-PUFA, how bad they are. So I usually was asked, what do I need to eat when I have my kind of bourbon in the evening or a couple drinks on Friday? And I said, I'm from Kentucky, and I'm telling you that Kentucky bourbon and Kentucky fried chicken is not a good combination. Thank you for your attention.
Thank you so much. I love your enthusiasm. Do you have a couple minutes?
Yeah, sure.
Okay. Hey, Dr. Williams.
Hi, sorry it's noisy in here.
Oh, it's okay. I just want to let you know we're getting ready to sign off to do the Cardinal Minute.
Oh, that's good. Just Jason never asked my question. I think you forgot.
Oh, I'm sorry. I didn't realize there was one in the chat.
Yeah, Dr. Williams' question. I know I ran around here.
He was too busy running from door to door to catch your call.
Dr. Williams.
Oh, hi, how are you? So pleased to meet you. So glad. Thank you so much for doing this.
Thank
The question
you.
really, I put the reference in the chat, but the big concern about the recommendation that Craig made, so I don't know if you're inheriting it or agreeing with it, about that we used to say 1 drink for women and 2 drinks for men. So it's kind of a question for him, but you're his right-hand person, so I'm going to ask you. We actually made that recommendation in the 2017 hypertension guidelines as well. And now American Heart Association, based on the data that's come out, is retracting that. It's saying that 0 is optimum. And that's really based on the cancer risk. So I put the reference in the chat. I think it's the guidelines from the Canadian Cancer Society with some references. And so I just wanted to know how you all were. It would ruin all of your entire program project if everyone decided, oh, it causes cancer, I'm not going to drink anymore.
So I don't think that people will follow that recommendations, don't drink anymore. It's so hard to convince somebody to not have a drink. But I totally agree. As a person, I feel like it should be 0 drinks. Well,
I guess we would be happy to be put out of business if it were for that reason.
yeah.
Oh, you would be good. That's right.
We
Yeah, if
could
it's
see other-
toxic to bet cells and myocytes and the liver, maybe we really should rethink it. But I know that's heresy. I'm in Kentucky now. So, all right. Thank you so much again.
Thank you.
Take care.
Absolutely. Thank you. Thank you.